Hi, everyone. Dr. Jacobs here. I just want to start out with this module by kind of doing a general content warning and say that this module, it's a 2-week module, but it is about suicidality and crisis. And there will be themes of those throughout this module. So please just, know that going into it. So in the US alone, suicide is the leading cause of death among individuals with schizophrenia between the ages of 15 and 44 years old. Until the last few years, very little research has examined suicide risk among people with serious mental illness compared to other psychiatric illnesses. This question about why that is especially relevant given that there has been increased attention to suicide prevention policies in the US with the newfound psychiatric crisis call center systems, with the rollout of the 988 number and the mental health crisis hotline that was rolled out in July of 2022. So there was a study that was published in Schizophrenia Research about a year and a half ago by the Yale School of Medicine that addressed this knowledge gap and concluded that people with serious mental illness are significantly overrepresented in deaths by suicide, even compared to individuals with other psychiatric diagnoses. Despite making up about 4% of the population in the US, people with serious mental illnesses accounted for more than twice, so it was 8.7% of deaths by suicide, according to their results. It is impossible to predict accurately which patients may make serious suicide attempts, but a thorough assessment taking into account major risk factors is critical in suicide prevention efforts while working with those that have serious mental illness. The assessment should be conducted within the context of a positive therapeutic relationship established using a supportive, empathetic approach. Key areas to evaluate are past suicide attempts by the patient or any close family or friends, access to lethal means, medication noncompliance, severity of their depression, intensity of command hallucinations. And command hallucinations are voices telling the patient to kill themselves, telling the patient they are worthless, telling the patient that they would be better off dead, and the patient's ability to resist those command hallucinations and severe paranoid delusions that frighten the patient. And examples of those would be warnings of terrible torture, warnings of being captured, warnings of being jailed. The assessment should also include areas that can be leveraged to prevent suicide, including supports, personal goals, future plans, and a sense of hope. Vulnerable periods that should trigger suicide assessment in the population with serious mental illness include illness onset, the active phase of these illnesses, just before discharge or soon after, or the occurrence of an adverse life event like interpersonal conflict, or the anniversary of like a major loss. So these words are common in serious mental illness, proactive and reactive risk assessments. So I'm going to talk about them a little bit. So for proactive risk management, the best approach in serious mental illness hinges on the assessment of risk in a proactive, structured, and ongoing manner. In proactive suicide risk management, there are initial and ongoing risk assessments that are essential. These risk assessments are probably what are familiar to many of you. They're conducted using scales like the Columbia Suicide Severity Rating Scale. They should occur at regular intervals, especially if there are no additional or increased risks. Proactive risk management involves a more proactive intervention like psychoeducation about suicide risk and the safety planning intervention and SPI. These interventions are implemented in anticipation that suicidal thinking and behavior may occur. For individuals with a positive assessment screen, the clinician would immediately end up doing a safety planning intervention and SPI. In routine treatment, the individual completes the SPI document with the clinician to develop a suicide prevention plan. This approach can be used during a treatment session and can be refined over time. The aim is to integrate the SPI as part of a standard care plan and revisit it regularly. So this is just a visual about it. And then some risk factors. There are obviously many more that we can identify. And then some protective factors. And again, there are many more protective factors that we can identify. So there are different types of risk factors. If you're talking about distal risk factors, and if these words are new to you, then these are much more commonly used if you're working in like suicide or prevention or in serious mental illness. Distal are background ones. Proximal are acute, and then warning signs are the most acute. So there are different specialized therapy models for suicide prevention. And these are 3 examples of that: collaborative assessment and management of suicidality, called CAMS, DBT, dialectical behavioral therapy, and cognitive behavioral therapy for suicide prevention. So I briefly talked about safety plan intervention before, SPI. It's a clinical intervention that results in the development of a 1-page document to use when suicidal crisis is emerging, just safety planning. So important to remember that suicide risk fluctuates over time, and the SPI is a plan for managing and decreasing suicidal feelings and for staying safe when these feelings emerge. The individual at risk completes the SPI. It can be done in a brief session. I'm going to keep saying it. It's refined over time. It's not a concrete document. It's a collaborative document. And it's important that the clinician and the individual collaborate to determine cognitive and behavioral strategies to use during the crisis. Some things that an SPI is not: it's not a substitute for treatment. It is not help for someone who is in imminent danger. So please, 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 please remember that. It is not a no suicide contract. I want to make sure that you all know that you must avoid no suicide contracts. That doesn't exist. So never make a promise, never have your client make a promise. All you're doing is asking them to stay alive without providing them like a coping skill. You're also asking them to promise something that they really can or should not ever promise. So what it is, oh, look, I doubled my slide. Sorry about that, everyone. So when you should be using it is you should be using it for crisis prevention. You don't have to use it just for someone who's actively suicidal. You can use a plan like this in other crisis situations. If you're using the Columbia Suicide Rating Scale and the number is a positive number, then you can use this. You can have your client do it annually or semi-annually and then just check it. It's also really helpful to use it whenever a major event has occurred, like a hospitalization, an attempt, an ER visit, a major crisis. Like I said before, this is a document that you could just continually be updating, or you can just have. If you're working in serious mental illness, it is very likely that you're going to have an SPI in your client's file. Your client will probably be very accustomed to SPIs, and it won't be something that feels like delicate or like something you shouldn't do. Using an SPI, having an SPI should be like any other note. And that is our presentation for this module. Hope you all are having a really good week, and I'll talk to you later. Bye.